Anyways, welcome everyone, and thank you for coming out tonight. This is very exciting. It's the last of many presentations today, and the last of talking about research that's come out of the Population Project, but not last forever. There will be more. It's just the last of today. And tonight is a Memorial Presents presentation, and we're really excited to have that. And you know, as the Labrador Institute, we're always happy to collaborate with everyone in Memorial, but in particular, the Harris Centre has been, you know, doing such tremendous work in Labrador and working with the Labrador Institute and many, many other partners in the region. So we're really happy to have everyone here and have the team all up and to be able to work together. We're also really happy to be able to have these conversations on the ancestral homelands of the Inuit of Labrador. And we recognize the continued connection to the lands and waters and how it ties into the research that we do, and in particular, the ways that we understand the research that's been presented today. And since this is our last one of the day, I also wanted to thank Jamie Jackman, who has done all the organizing and logistics for these events and run the live stream. And if you've been watching him throughout the day, we gave him a tripod that doesn't have a handle. So the poor guy's been spending all day manually turning. He's done a wonderful job and worked out on the technology. So those of you who are coming in virtually, we'll have a chat section on the channel that you're watching. And so if there's any questions or comments that you have, you can just type them in, and we'll be sure to address them throughout the event. But with that, I'd like to welcome up Rob Greenwood, who is no stranger to everyone in this room, because I know everyone knows Rob, but also no stranger to the work in Labrador and to public engagement and to linking community and university and research together. And in particular, just the continued connections that the Labrador Institute and the Harris Centre have had is just such a lovely thing. So welcome, and thank you, and always great to have you back in Labrador.
Wonderful. Thank you, Ashley. And Ashley has been in 4 sessions now with us today. So, and several folks here have been in several sessions. So thank you all very much. And the Population Project is something the Harris Centre started about 4 or 5 years ago. And our advisory board, which includes Tim McNeil from the Nunavut government, had emphasized the Harris Centre. We have a whole bunch of things we do, but that there were several key issues in the province that we really need to pull budget together and systematically focus on a key theme to advance public policy and regional development best practices to help inform governments and community organizations. And so after some brainstorming, it all focused in on the demographic challenges in the province. And so we asked Dr. Keith Story, former head of geography at Memorial, to take on the role as research director. And the International Grenfell Association funded the initial part of the work. And of course that focused on Labrador and the top of the Northern Peninsula. And I'll let Keith say some more about that momentarily. And so we've been trying to get the rest of the funding together on the project, and we're almost there. So there will be more work to come. Really appreciate people coming out in the evening. We are live streaming, and as Ashley mentioned, people will be able to email in questions. And the team we have from Memorial has been participating throughout the day as each other presented, and I think it's really led to some really rich discussion. So we'll do maybe a quick round table for everybody to introduce themselves. And Jamie, I think, was introduced, but you can introduce yourself again if you like.
Sure, okay. Let's get a shot of everyone first, just so
there you go.
Okay, my name is Jamie Jackman. I'm with the Labrador Institute. I'm program coordinator.
Super.
And I'm Ashley Consola, I'm the director of the Labrador Institute.
Dave Lowe, I'm involved with the faculty business in Memorial.
I'm Deb Thompson, I'm with the Department of Health and Social Development in the Nunavut government.
Gary Mitchell, I'm a member of the Nunavut Assembly and chairperson of the Nunavut Inuit Community Corporation.
Franca Smith, I'm a senior analyst with the Labrador Affairs Secretary with the provincial government.
Yes, Sparks, I'm a retired nurse.
Don Sparks, senior citizen and part-time associate with the Labrador Institute.
Alvin Sims, Department of Geography and the Harris Centre Regional Analytics Lab at Memorial University.
Kris, I'm the director of the Primary Healthcare Research Unit at the university.
I'm Stefan Yevchik, I'm professional planner, and I did the housing study component of the population project.
Keith Story, I'm the director of the population project for the Harris.
I'll let Keith continue to hold the floor and tell you a little more about the project, and then he'll introduce our speakers. Thank you.
As Rob indicated earlier, the population project is one of a number of projects sponsored by the Harris Centre. And in this particular case, the focus is to look at the policy implications of demographic change in the province, and the time frame we're looking at that is over the next 20 years. And as I have mentioned to earlier, the previous provincial government, the Conservative government, introduced a program called the Population Growth Strategy for the province. And the primary focus there, not exclusive, but primary focus there was on growth through either more babies or immigration or holding on to that population through retention of people, encouraging them to stay in the province. Our focus is different, and that we are looking at how we can change various systems, given that we're going to have an aging population, fewer people available to work, and less money, because there are fewer people paying income tax for a start. So the project looks at the implications of demographic change and what we can offer as policy recommendations. The way we started was by developing a number of population projections as a baseline against which we could examine various outcomes and subsequent research. And Alvin and his colleague Jamie Ward generated those population projections for us. And we then developed a series of research projects in consultation with people in the area to further this particular interest in development policy. We focused on Labrador to begin with. We were lucky to get a significant grant from the International Grenfell Association. And so, as of today, Ashley mentioned it, we have completed 9 different projects, and another one will shortly be completed. I am the director of the projects. I don't do the research. I'm the director, and the reason I'm with the director is I'm the poster child for the project. And the poster child in the sense that I am old. I'm a drain on the economy. I draw a pension, and I'm getting increasingly expensive to operate. Bits fall off, bits don't work quite as well. And so the particular project that we're going to listen to this evening by Alvin and Kris is very relevant to my particular interests, because it looks at the human resources implications of demographic change on the medical system within Labrador. And Alvin, as you heard, is with RANLab, which is the statistical unit, which is part of the Harris Centre, and Kris is a practicing doctor in family medicine and director of the primary care research unit, if that's the right title, with the Faculty of Medicine at Memorial. And I'll leave them to tell us what we can expect in the future with respect to healthcare resources.
Titanium.
Thank you. Yeah, right.
Okay. So Kris, hold you the first. Thank you, Keith and Rob. Actually, the way we're going to do this tonight is that I'm going to talk about the data and the model, and Kris will talk about the outcomes rather, incomes. See, I'm already thinking money here, thinking about the outcomes, and basically because of his clinical background and whatever. And one thing that we strongly encourage is multidisciplinary type approaches to looking at our problems, sort of thing. So whenever we can partner with experts, whether we're doing healthcare, we try to partner with experts in healthcare and so on. So the title of what we're doing today is Predicting Health Human Resource Needs for an Evolving Population in the Labrador-Grenfell Region Health Authority. Okay, of course, study area, sort of thing is the Labrador-Grenfell region, which includes the northern tip of Labrador as well as all of Labrador and the regions that are here. And I should mention, because of data limitations, we had to look at this analysis from the Labrador-Grenfell Health Authority region because some of the numbers were small and access to data, as anyone working in healthcare research knows, it's always a challenge to get information. Okay, so the scope of the study, the idea of our project is to forecast healthcare demands associated with the next generation of seniors in Labrador, or the Labrador-Grenfell Health Region. And basically what we've done is we developed sort of a model where we look at age-specific demographic forecast models paired with expert information, which I'll talk a bit more about later, to an age cohort utilization factor for human resource requirements and healthcare setting type. Now, one of the things that we did in the project is that we can only get data for 6 facilities in the Labrador-Grenfell region. One of the issues of why we're doing this and the whole idea behind this, if you look at a lot of the data that's been published and a lot of the information coming out from the Department of Health, from the Newfoundland Medical Association and so on, we have the oldest population in Canada, in this province. I can tell you from doing a lot of work and a lot of analysis around different parts of this province, I looked at one community recently, the median age in the community was 56. There are communities with no younger cohorts present in their populations, sort of thing. And some of the big stressed areas of Labrador is the Labrador Straits, some of the South Coast area. Some of the regions that are fairly stable population-wise is Central Labrador, which includes Happy Valley, Goose Bay, and Lab West, and Labrador City, and Wabush. Now, the other thing that comes into play here is the health costs per person. In this province, we're about 20.5% to 22% higher than the Canadian average, which is, it is because of our geography, sparse populations, and other things that goes on. Approximately 63% of the population over the age of 12 have at least one chronic disease, while 88% of the seniors. And in our report, there's detailed literature review on all these things and where the numbers come from and stuff like this. And on average, seniors use the healthcare system more often and stay longer when admitted to a facility, sort of thing. Okay. Now, one of the things that has been evident in terms of visitations and admissions and so on is that the number of seniors requiring a caregiver will probably double in the next 30 years. And this is really problematic in many rural areas because rural areas are aging faster than in urban centers, and we see this even in Newfoundland, where I would say 85% of young adults between the ages of 20 and 24 are living in the Northeast Avalon. And most of them have come from rural parts of Newfoundland. As a matter of fact, the growth in the Northeast Avalon, majority of that growth has been interprovincial migration, i.e. people moving from other parts of the province to urban areas. So that's there. The other thing that comes into play here is the out-migration of youth from a lot of rural areas leaves a really noticeable gap in familial caregivers. And basically, if we're going to switch to some sort of model where you've got in-place healthcare, home care, who is going to provide that service? If it's not a familiar person, you still got to hire someone to do it, and then it becomes the idea of a labor shortage. So therefore, you have the conundrum that you want to have place-based home care, but yet you may end up falling back onto the healthcare system for support. When the idea was to become a bit more independent of it. So, we have a whole series of population projection models, which is our starting point. And what we have, for example, we have two models, and one we use for a part of the study. In the report, there are two models reported. And we use what is called a medium historic survival projection model. And simply what that is, we look at probably 10 or 12 years of migration data and behaviors in the population. We look at fertility, mortality, and all these other things. And we actually forecast into the future, assuming that those cyclic trends continue over time. So basically, the upturns and downturns in a population are accounted for, but they are cyclic. You know, you got a boom and you got a bust, you got a boom and you got a bust, and you try to average out how the population will go. No matter which population model you use, there's one undeniable fact, and that we will have a very high proportion of the population over 65 between now and 2036. And no matter which way you look at it, if I can sort of point out to this bump right here, no matter what model you use, we can use a growth model for Labrador. That particular bump that we see here increasing in the number of seniors between 65 plus, that's going to happen no matter what you do. That cohort is going to impose itself on the healthcare system, no matter if this place grows and you maintain the population or whatever, or it declines, you know, sort of thing. So it is there. Okay, so what is our analysis based on? Well, we did a lot of research looking into different types of demand models and stuff like this. As a matter of fact, the primary healthcare research unit came up with the survey methods and whatever. And we surveyed healthcare professionals. They were clinicians or practitioners. Some of them were, I think there were licensed practical nurses, there were registered nurses, nurse practitioners, and so on. There were one or two physicians, there were physiotherapists, and so on. The whole gambit of the healthcare system, sort of thing. So what we did was that we asked each of the clinicians how much time did they spend, sort of thing, to the care of the population within a specific age cohort. And the age cohorts were based on the, what types of things you would need given that age and propensity for certain things to go on. So what we did, we took the survey data, which I'll talk about shortly, the 2016 population, plus hospital admissions by age cohort, and then that gave us a calculation for the human health resource demand that's currently here based on, say, 2016 population. And that's our baseline. Okay? So then we take the survey data, we integrate that or combine it with an age cohort hospital admission data and population projection models to forecast the health human resource demands for the future. And so basically then we take the current, sort of thing, health human resources versus the projected ones, and then that's our change in future demands. Putting it in a simple way. Now, what the surveyed health professionals estimated was the percentage of time contributed to patient care for the specified age cohorts. Okay? And so at the end of the day, we use that to estimate the patient load change for each clinical specialization. And so in this study, when we talk about the age cohort, we look at weighted patient days. And it's a way for us to be able to compare in a relative sense about how the demand will increase as the population shifts to that older cohort, sort of thing. So this is what we do. So basically, what we have to do is that we know that patient days contribute to the magnitude of the impact, i.e. the number more of patient days that you have to put into the system. But the forecast population contributes not only to the magnitude, but the direction of impact. So if you're shifting from a predominantly younger cohort to a much older cohort, like 65 plus, your direction then is towards the older cohort. Secondly, sort of thing, we use hospital admission data, and it's from NELCHI, Newfoundland and Labrador Institute for Health Information, and we got the data, sort of thing in terms of admission. We have average length of stay by age cohort, sort of thing, and we assume because we have no other information at this time, that they do not change over time. Now, normally when we look at changes in fertility and other factors in the population, they're usually cultural things, and usually takes a generation for some of these things to change. But one thing we have noticed, that the declining fertility rates and other things that go on in a population do not change in 5 or 10 years. It usually takes longer for that event to rebound if you're going to encourage people having more children or whatever. It doesn't happen overnight. They tried it in Quebec with a policy, and it didn't work. You know, sort of thing. I think they're offering $1,000 or $2,000 per child as a one upfront cost. It didn't change the fertility rate whatsoever, especially in rural areas. So basically then we also make the assumption that even if the stay times are reduced, i.e. the stay days are reduced in the future patients, they will require some type of home care and resources. So no matter which environment that you put the patient in, they will require some sort of support services from the healthcare system. You know, they're not going to be just left there, you know, monitoring and managing themselves effectively, as I'll talk more about later. We also assume that fertility, mortality, and migration rates follow historic trends. Now, I always make a recommendation in these kind of models. If there is a major shift in an economy or a growth factor, you should rerun those again. We usually rerun these models after every census and update them. You know, that is the proper way to do this sort of stuff. Okay, so what we did, we went and did the survey, and what we have here is the average percent time contributed to each cohort. And as you notice, here is that, you know, you look at registered nurses, and you look at between the 0 to 2-year-old ones is like almost 29% in that list right here. You got to read by column. So the effort and care on average of these patients of these age, so 28% of the time is attributed to a registered nurse, but over when you get to the 65 plus, it's up to down to 14%, so there's a slight decline there. But you will notice with a nurse practitioner, it goes up by almost a factor of 3 by the time you get to 65 plus. So therefore, as patients age, you know, sort of thing, the demands change. The family medicine and physician practitioners, these guys are pretty well, they slightly increase, but they're pretty, you know, evenly loaded across that, but you get a slight increase and so on. And you notice with pediatrics, they disappear after you're 17 years old off the chart, you know, sort of thing. So this is the baseline information about time allocation and so on. So then what we do is that we look at we take the data, and then what we do is we look at the population in each of those cohorts. So you can see, you know, sort of thing, there is a majority of the population in this cohorts right now is only like 1,220 between 0 and 2 years of age. And yet, you know, right now there's a little over 5,000 65 plus. There's 11,000 between 45 and 64 years. In 20 years' time, there's going to be a large proportion of, well, all of those will be 65 plus, you know, sort of thing. So you can see that number jumping up quite high at that point in time. Then what we did, I actually requested at the time to have all the data for nursing stations and every facility that was under the Labrador-Grenfell Association. And the only data that was made available to me in a timely fashion was, you know, the Charles S. Curtis Memorial Hospital on the Northern Peninsula, Labrador Health Center here in Labrador, Lab West Healthcare, Strait of Belle Isle, White Bay, and so on. And so these are the emissions that are there that you're emitted into a facility, you know, sort of thing. And that's the 2016 data, 2016 to 2017, start and end dates. And you notice here that, you know, a lot of the emissions are in the older cohorts already. What we do then, we take this data and we convert it down to ratios and stuff like this. And if you look there, you can see only 3.4% of the population is between 0 and 2 years of age. 30% of the population, or 31%, is 45 to 64, 33, 18 to 44, and only 14% at this point in time at 65 plus. The percent of total emissions, you know, sort of thing, you notice that as you get older, the percentage of emissions go up. Like, for example, 0 to 2 years of age represent, they 3% of the population, they represent 6% of the population, almost 7. You know, and 3 to 6 year olds is only 2%. But then you get down to 45 to 64, it's 34%, and so on. This number over here is that if you take the population in an age cohort, you look at the ratio of the total population in that age cohort, and the number of them that were admitted at least once into the healthcare system, you would get these numbers. So for those who used to work in healthcare, you know, we use the word hospital morbidity, but there's confusion over that number with the word morbidity and stuff, so we are now using percent population admitted to a hospital.
Who knows morbidity means admissions?
Well, Kris and I had this discussion, there is a debate over that. but I just think of admission rates, that's what in my head, right? But anyways, but interestingly, you know, sort of thing, you go down to the 65 plus, you know, it's 41%. And there's a high number as well for the 0 to 2 year olds and so on. But you also note the 45 to 64s are up at 43%. And what we do there, and this will be soon for Kris to take over, is that we established a baseline. Now, these numbers, I'll be honest with you, may not reflect the exact number of patient days exactly, but it gives us an idea of the distribution of demand by clinical specialty. And if you notice down the side over here, you notice the percent demands for each specialty. And down here, you notice the percent, for example, percent of total age cohort patient days. And you'll notice already the 65 plus account for 40% of those. 71% of those patient days are accounted by 45 plus age cohorts and so on. So I'll let Kris take this over now and get on to the other outcomes. Thank you.
Thanks, Alvin. So Alvin is very kind to let me present because this is really mostly his work, but I will get to take some credit by being up here in front of you. The next few slides are really going to be the same data, the same results, just presented in slightly different ways, just so to clear up some of that confusion, or potential confusion. This particular slide, you can see there's columns there for 2021, 2026, 2036, broken down in the different years. And that's the percent change for that particular health professional type from 2016. How much it's going to increase or decrease in the case of a few there. So you can see, not surprisingly, geriatrics, the percentage increase in requirement for geriatrics is going to be quite dramatic, 63%, 64% by 2036 is what we're estimating based on one of the demographic changes. Orthopedics, also quite a big increase. We know joint replacements and fractures from falls and that sort of thing. Right down to pediatrics, again, not surprisingly, there's a quite substantial decrease in the requirement for pediatrics at the bottom and various things in between. But of course, there's dramatic differences in the number of those providers that currently practice in Labrador. So in terms of the absolute change in requirements for those different practitioners, this is what we have on this slide. So this is the number of patient days that we can attribute to the different provider types, the absolute patient days in 2016 to 2036. We've got rid of those intermediate time periods for this one. And you can see family medicine being one of the most common provider types. There's the largest requirement for family docs by 2036, but that only works out to a 14% change versus a relatively small absolute increase in specialized geriatrics care at the bottom in terms of absolute numbers, 700 or so days, which is the 64% that you saw on the previous day. So that just, same data, but just expressed in terms of absolute days attributed to that provider type. And of course, we have to reorganize that to calculate the number of full-time equivalent providers, which would be relatively straightforward to do, to estimate at least. This again looks, again, you got 2021, 26, 2036. Compared to 2016, the requirement for the care of 0 to 2-year-olds will decrease to 90% of current levels, 72% and 61% by 2036, if you look on the leftmost column. And then over on behind the speaker for me, 65 plus years, again because of the aging demographic change, 180% increase in the hospital days for that particular age group by 2036. So dramatic increase. What we didn't see, but for those of you who were here this afternoon, you might remember, I think it was discussed and mentioned in one of your presentations that we're projecting an increase, or Alvin is projecting, I won't take any credit for the demographic change projections, an increase in population by 2026, but a slight decrease by 2036 in Labrador population. Despite that population decrease, there's still going to be a dramatic, in my mind, a dramatic increase in the total requirements for health care services. And this shows that what that quantification or how that works out in the numbers here. Again, on the right-hand side, the total days. I think everybody can see it there on the right-hand column. The total days, 148 estimated in 2016, up to 2036 of 167. Average patients admitted to Labrador-Grenfell institutions every single day, 168 patients in 2036 versus, 167, 148. So again, similar data, but just broken down in a different way. But this breaks it down by the different age cohorts in a different fashion to see that the relative admission rates for the kids, once they get out of being a baby really, is very small because they're relatively healthy, of course. So to summarize then, the Alvin's projections are the region's population over 65 will increase from 14% now, or in 2016, right up to 30% by 2036, so over double what it is now. That's very close to what is being projected for the Newfoundland, for the province as a whole, which is estimated at 31%, so not much different. Again, as we've said in several slides now, the 65 plus cohort will increase dramatically, whereas essentially all other age cohorts will decrease if the estimates are correct. And they have been. So the testing of the models that have been used so far, they've been very, very accurate in predicting, for example, the 2016 census profile for different regions of the province. And as I've said several times as well, increase in overall healthcare demands. Overall, that increase in healthcare demands will gradually, it'll gradually increase over the time period up to a level of 14% from current or 2016 levels. Will affect some health human resource categories more than others, as I've said as well. And of course, it's going to be preferentially those that serve seniors the most. Geriatrics and orthopedics are the ones I mentioned before. But those other types of providers that are the most common deal with a broad range of ages will have the greatest absolute increase in total provider days, total provider requirements or full-time equivalent requirements. The family medicine registered nurses, nurse practitioners, and LPNs, I think, to a similar extent as well. And Alvin in his work has used different assumptions in some of the models to predict the population. So whether there's a new industry that comes in and a requirement for more young workers to move into the area to serve the needs of that industry, he's made some assumptions and developed some models that incorporate those types of really guesstimates in terms of the new population requirements. Regardless of what any realistic, likely, possible model is used, there will always be, in any of those models, there will always be a dramatic increase in that 65 plus population and a dramatic increase in the health care requirements for that population. But some of the in terms of limitations, this is relying on current patterns of healthcare delivery. I think most of you know, certainly I know, it's something that I deal a lot with in my work, is that there's a change in the way healthcare is delivered. There's been a dramatic decrease over the last number of years in the use of hospital stays and an increase in trying to provide care at home where that's possible and feasible. We don't know for sure how that trend, whether that trend will continue. My own impression is that it's probably getting to about in many places at least, it's getting to about we're getting to deliver as much care as we can in the home, and so it's unlikely to continue much anymore, but who knows what the future will hold. So that may affect our predictions. Regardless of where the care is delivered, you're still going to need healthcare professionals though. So it's unlikely it'll certainly affect, or it may affect the need for bed days, hospital bed days, but it likely won't have too much of an effect on the need for health care professionals and the different types of professionals. That pattern of care delivery, whether in hospital or at home, and relying on family care providers and versus professionals, may also be affected by out-migration of the young workers, right? So it's the young family members that often play a big role in the care of their elderly family members, and so if there is out-migration, then they'll have an increased reliance on professionals. Some of the potential solutions to mitigate some of those issues would be an increased reliance on health practitioner teams, so using different professionals to the maximum of their scope of expertise to minimize the more expensive providers like physicians, and more use of telemedicine to deliver services remotely. Telemedicine is used in Labrador to a fair degree, mostly for care delivery along the coast, but not to a great extent elsewhere, and predominantly, except for the coastal clinics, predominantly for specialist care is my understanding. It's used much less on the island for primary care, for family physician services, and I know that's not the purpose of this presentation to talk about the island medicine, but I think there's probably increased capacity and capability really to use telemedicine to mitigate some of those health services delivery issues to some of the smaller communities that may not have the sufficient size to support a social worker, for example, or a therapist, occupational therapist, physiotherapist, or family physician even. So that may help. The other things I'm going to add to some of the stuff here are that we will need to recruit new providers, but we'll need to train new providers. So I think the faculty of medicine, I'm involved with faculty of medicine, so I'm most familiar with what they're doing. They have increased enrollment in the faculty of medicine in recent years. There is a residency program in family medicine that's based here in Goose Bay, as I think most of you likely know. But Michael Jong, one of the champions of that program, or is in the process of retiring at least, and so it will require someone to take on his shoes to maintain the quality of that program. And I think that's been a huge, huge support in recruiting family docs, at least, to work here locally. So, and all the literature suggests that that's a really important part of rural recruitment and retention, is training people in the environment where they'll practice. Similarly, nursing programs, social worker programs, I would expect that the literature is something similar. I'm just less familiar with what's happening in that area here, but I'd suggest that the need is similar. There. The other parts are the reorganization, I think, of care delivery and best use of other providers that I mentioned before. So that's what we had to say. Thank you very much for your attention. Thanks for your attendance. It's great to be able to talk to you folks about this sort of thing, and to really come to where the information might be used. And I really appreciate the opportunity and your hosting. Thanks very much.
One of the things that, the primary reasons that we are here with these, presenting these various projects, is to get some feedback from people. Following that feedback process, we'll finalise the reports, and they'll be made available very soon. So if you have any comments now, or ideally now, but if in the near future, if something comes to you, if you would like to communicate with Awesome, Alvin and Kris. That would be wonderful, but for the time being, if you have any thoughts or comments on what you've heard here, we'd be very glad to hear them. Yes.
I just had a question. Your data, did it take into account Labrador residents who had to leave Labrador to get treatment?
No, well, we didn't do the transference thing because we didn't have access to the data. But that's the next phase that we'd like to get into is the idea about what patients are transferred to what acute care facility when you go to a higher level care.
Right.
And that's something that actually, I'm involved in another project that's hopefully we're looking at about 140 community healthcare centers in the province. And I've been asking for this kind of data for a long time, and it looks like we might get access to it, you know, sort of thing. And this is actually the first step as I see it. And I think we need more detailed data. If we had more detailed local data, we could probably do stuff down to, say, Central Labrador, North Shore, North Coast, South Coast, the Straits, and Labrador West. You know, so that we had access to the kind of data that we know that's out there. But one of the problems that we're finding, and I've been talking to clinicians and other people who are working with healthcare data, is the fact that there is information on how much time that some clinicians spend with patients, but the way it's recorded and standardization of it is somewhat different from place to place, as you know. And I think with the work that Kris and his group did, it's probably the first time that we standardize something in a certain way. We use a Delphi method where each of the panel were asked to reevaluate after about 3 or 4 rounds, I think it was, Kris? Until we got stable answers about the time, and there was agreement amongst the different clinicians about who was being allocated what, you know, sort of thing, right? So, but we think this is probably the first time this kind of thing has been done, but there's a lot of space for us to expand it and do more detailed work, which I think is needed here.
Absolutely.
Especially when you start changing the model of delivery.
Have you considered maybe looking at making the aging population healthier as they age, so they don't need to access the healthcare system?
There's
Like do the preventative education, those kinds of pieces now?
Yeah, so there is a lot of work on that. It's not really something that was addressed in this project at all, but there is other work in other projects, of course, that, and I'm involved in at least one of those. There's also, you've probably heard of Health My Way. It's not exactly what it's called, but it's a chronic disease self-management program that has been implemented quite broadly across the province and has good data for it from elsewhere. We don't yet have, at least not that I'm aware of, data from Newfoundland about how the outcomes have improved with that, but there's also a chronic disease prevention and screening program implemented in a clinical setting that I've been involved with and is starting to be rolled out on a smaller scale as a health system program. I think it has to be, we have to do way more though, way more. There's got to be, it's a bit of an aside, but it's got to be education, it's got to be, it's got to target all the sectors to really be able to make a systematic, a substantial change in population health outcomes, to be able to prevent those outcomes in a big way.
What would be the time frame through education? That's something that we could implement it, that if the adoption rate was at a certain level, sort of thing, and the outcomes could be somehow monitored, sort of thing, because that could affect then, sort of thing, the number of admissions for certain chronic diseases and stuff like this. I had a student, actually, he works over in your shop right now, looked at the migration of patients to other centers where they could get care for their chronic disease. And that's what you're, in some cases, talking about, like people actually move to a place because they're near an acute care facility, as opposed to staying in their rural community, sort of thing. But that I sort of looked at in the literature, tried to find stuff that you were talking about, how education changed outcomes. And there's very little out there, in terms of like, actual results, right?
Yeah, I mean, if you look at education on its own, there's really not very convincing literature that makes, increasing the physical education in schools, for example, changing long-term health outcomes. But it's intuitive that it would make a sense. There's some literature to suggest that it does make a change. And little things, so a combination of little things in different sectors, I suspect, will be required to make a substantive change in health outcomes. So I'm talking about education, I'm talking about housing, I'm talking about urban planning, to organize our communities in a way to encourage physical activity and commuting under own power. I'm talking about taxes on unhealthy foods potentially, and all those sorts of changes that are really required to make measurable differences in population health outcomes.
One of the things that, one of the programs I'm involved in as chairperson of the Untitled Corporation is we run a community freezer program, and we try to stock traditional foods as much as we can. And we're looking at the person's health, the senior's health in this regard. Not just, it's not a food bank as such. It's a means of trying to promote healthy living with a little bit of traditional foods that we have left, that we can have access to. So we get about 100 households, or sometimes up to 120 households, taking advantage of community freezer, whereby we stock moose, partridges, rabbit, berries, and fish. And those are the only kind of, and now we have seal meat. Those are the only kind of foods we carry. We don't carry like chicken or roast or things like that. We're trying to keep it traditional because we're looking at the person's health. Any little bit helps, like we were just talking about, any little bit helps to promote their health mentally and physically, it helps them. And the only thing is, we don't have a big budget for this, and there's not many provincial government programs that help out with that. If there was, then we could access more funding and have bigger inventories for when there's nothing in stock, because we work availability like as we work the seasons.
Yes.
So if we had more funds, we could stock more fish from the summer to carry over in the winter, instead of paying the high prices like $7 a pound.
Garrett brings up a really good point, because there are community freezers in all the Nazi communities, and a recent study has shown that a couple of the communities are very highly food insecure. People are, there isn't enough food in the community. You're figuring out. And like Maine and Oakdale, I think, are two of the highest. So I mean, we're looking at people's primary needs not being met.
Yeah.
And I don't know if that's going to shift or change, but.
Well, I lived with Chippewa First Nation for a few years, and nothing has changed really, like in northern communities, since 40 years ago. In terms of having access to food security. I mean, it was the odds and base store was the main place to go to then, sort of thing. And what you got there was not considered healthy from my perspective, anyway. So.
I think it's very interesting that you mentioned mental well-being as well as physical well-being, because that's how I feel. This is much to do with my health.
Because these seniors that come to pick up a few things, mentally it helps them, because they know they're going to have something that they enjoy. It keeps them going. It gets them out of the house and come down to the building and pick something up, and that helps them. It keeps them mobile. They have a little bit of interaction with other people that might come into the building, so it's mentally, yes.
That's all the kinds of small things that you're talking about.
Yeah, it's something that hasn't been paid. There hasn't been a lot of attention paid to it, I think, within the health system, but it's changing. About the importance of community, the importance of social supports and health outcomes. There's a dramatic study from one town in the UK, where there's initiatives within the health system to reach out to isolated seniors and get them involved in programs and community programs and those sorts of things. And they had huge improvements, dramatic improvements in the emergency department visit rates and the hospitalization rates in that community over the time period of the study. Now, it's a small-scale program that needs to be replicated elsewhere to know for sure whether it was cause and effect, but I think starting to initiate programs like that will make a substantial improvement. Again, another small piece of the puzzle to try to improve outcomes.
In the UK, they now have a minister for social isolation. Yeah.
So, you know, what a difference. I mean, you never think of that.
Yeah.
You know, a generation ago.
I'm sorry, I didn't mean to interrupt the flow of questions. Any other things that you'd like to raise?
One of the things that caught my eye when you were doing the presentation was that there's going to be a shift from like hospitals to more home care. Maybe I'm wrong. Maybe I heard
Yeah, that's been actually, well, Kris had talked more to it, but in the literature, in a lot of other jurisdictions, that move is pretty common, going from acute care to primary care and shifting as much as you can to home care, so the person's in their own place and not in an institutional environment, you know, sort of thing. And that's, I know they're trying that in rural Saskatchewan, they're trying it in other countries and stuff like this as well. But Kris can talk more to the shift to primary care, because, you know, that's his thing.
Yeah, so if you look at the population data, there's actually a decrease in hospitalization rates over the last 10 to 20 or more years, 30 years even, in most areas. It's less so in rural areas, and that's for a couple reasons. Hospitalization is really expensive, of course, and it's also unhealthy. So within the hospitals, you're exposed to lots of chronic diseases, and you can get sicker in hospital rather than better, which is more common than we like to admit. So for both those reasons, we're trying to deliver care in the community with nurses that go to your home and give you antibiotics, or that's probably the best example, but getting people physiotherapy after a joint replacement at home rather than staying in hospital for a long period, those types of things. There's less availability of those home care services in rural areas, just less healthcare providers in general, so it's happening less in rural areas, but you may see, depending on how the health economists crunch the numbers and plug the numbers, you might see more of an emphasis on that. That being said, I'm a little bit of a skeptic about that. It's expensive to deliver care in the home as well, and a lot of the calculations, maybe this is too in-depth for this purpose, but a lot of the estimates and cost savings are based on average cost of a hospital stay. But if you have a hospital that has 1,000 beds, the cost of the last 900 hospitalizations is relatively small compared to the average cost of the other 900. So I don't think you'll save as much as they're estimating you will, and so it may not be as sound policy as what they're estimating.
I just wonder, like, if there's a shift like that to more home care, what about, because people are in hospital for a reason, they need medical attention, so what about these people in home care, you still will need the medical attention? So does that mean home care workers are going to have to be more qualified to administer?
Yeah, so they're only implementing these programs where it's safe to do so. So not in someone who's had a heart attack who might have a cardiac arrest and needs to have a resuscitation, for example. But in someone who has an infection that's not too bad, it's bad enough to need IV antibiotics, they'll have nurses, registered nurses, the same as work in the hospital, that just go to the home and give antibiotics at the home to the patient. They'll implement short-term services of a home care worker to go in and help the patient bathe if they're too weak to get up and bathe while they're recovering from the illness. So it's a combination of home care workers, the same as what it sounds like you've experienced already. So they're not trained healthcare professionals. They have limited training on how to do certain things, but as well as the registered nurses and the trained professionals, and physicians in some cases, nurse practitioners. There's an increased interest in doing home visits by both physicians and nurse practitioners, and we encourage that actively in our residency program, for example, to deliver care early to the seniors in the home so that we can prevent them deteriorating in their pneumonia or urinary tract infection, for example. If we treat them early in the home, then we prevent them from deteriorating to the point that they need hospitalization, for example.
When David Foote, the demographer, talks about the boomers after the war and big families, and we're all aging in that cohort, so that use the analogy of the python swallowing the pig. The big snake and the pig were all that bulk as kids in the 50s and 60s, and then teenagers and so on, and now up to. And everything you're saying makes sense, and over the next 20 years we got to deal with this, and there's going to be big costs. We won't be here, probably. Young ones will.
I'm hoping to still be here, but
I've had it to be 104, but that's another matter. Unless Alvin kills me before then. So. But in 30 years, in 35 years, in 40 years, doesn't that bulge go away?
Yeah, pretty much.
Yeah.
And basically, this is the thing that's going to happen. And I said, when someone was arguing today about Labrador has got a lot of potential for growth, especially in central Labrador and Apple Valley Goose Bay and the North Coast and stuff like this. But that's not the point. Is that, yes, even if you grow, that's going to flatline and it's going to decrease. And there's going to be that big bulge will be removed from the population. And there's nothing coming behind it that would suggest there would be enough to replace them. So that 30% that we're talking about, sort of thing, there's not enough behind them unless you've got some sort of migration, in-migration, something else that can replace them, sort of thing. So it's going to be one of those things that's going to happen. It's going to be a big stress for a decade or two, and then it'll start declining. And basically, we can see that disappearing, sort of thing. Because people that are 65 now will be 85 by that time, and they'll be going to their greater glory, as we say, sort of thing. And basically, the ones coming beyond it that are 45 now will be turning 65, but there's fewer of them coming through than there is already 55 plus now.
And if you're investing in hospitals, or much infrastructure lasts 40, 50, 60 years. And so don't freak out over the next 20, 30 years. Yes, we have to take it seriously, deal with it. But in the life of a province, a 20, 30 year period is not forever.
But it could be 50 years, right?
Yeah.
But even though that bulge moves through, your 45-year-olds are now 65. You've got a smaller group coming through.
But it's smaller again.
It's smaller still.
It's staggered.
And so, you've got a smaller group that have got to pay the cost of, albeit a smaller group, but nonetheless, it's proportionally.
Proportionally, unless there's some sort of, as I say, renewal of the population some way or another, sort of thing, right?
Or, and this is an economics discussion now, it's why productivity gains and innovation, we don't lack for natural resources or opportunities in this province, but we need to seize them, fulfill them with far fewer workers. And technology is moving in that direction.
Can I ask a question? Back in 2 slides before, you talked about 14% increase in patient demand by 2036.
That's overall average.
Overall average. Can you do a back of the envelope to say what that would mean in terms of costs? Because it won't be a straight 14% increase in cost. Right?
Well, I mean, it was 5,000 per patient, and you look at cost per patient days, you can do it.
But it's going to be, if you look at the particular categories of healthcare professionals that you need, is it the more expensive ones that are going to be in greatest demand, or the lower cost ones? I mean, in other words, does that cost curve go like this, or does it, flatten out?
Yeah, it's there's so many. There's 15, I think, healthcare provider types there, all with different changes in percentage. I mean, so there's no way that I can.
You didn't know, God, I didn't know if you.
But it is a big number.
Yeah.
I suspect we can do a lot more with non-physician provider types than we're doing now.
Right.
And so, and by and large, they can do better most of the time than physicians. At least as good, if not better. Whether or not it's truly cheaper, because there's other factors that affect the cost of care. But I think we can find ways of getting way more efficient than we are now, is the bottom line. So it's not going to be, not necessarily a 14% increase in the cost.
Okay, could be, change it. And then can I have one more question? As the chair of the session, can I? Telemedicine. We hear about the robot in Nain who, can wander the halls, Rosie the Rose, who wanders the halls of the hospital and communicates back to
Yes,
St. John's.
yeah.
Brilliant.
Yeah.
But to paraphrase your statement, we don't use telemedicine elsewhere in the province as much as we might. Why?
That's right.
Why not, I should say?
It's yeah, it's a good question. I don't know the full answer to that. Traditionally, it's been, I think there's a historical answer is the main answer for that, and that is most of the time there has been family physicians fairly broadly distributed across communities, across most of the country. Even in fairly small communities, there's often a family physician. So they're usually able to provide the primary care locally in their community. And so typically, traditionally, telemedicine has been used for delivery of specialty care, which are predominantly, of course, concentrated in the cities. So they use it to overcome those barriers. And so historically, that's just been the pattern, and we've never really branched out as much as we could into family medicine. Even here, where they've started using it in primary care, the impetus was, I think, it was mainly for emergency care. So, so emergency care, urgent things that came up on the coastal communities and the nursing stations. I think that's what they mainly use Rosie for. But because the family docs are delivering mostly emergency care, they're exposed to it, they're used to it, and they've started using it more for the delivery of true family medicine, primary preventative care as well now. So I suspect.
And does that model, do you think that model is likely to carry over into other locations? Or is there much drive to make that happen?
I think there is now. I think there is now. It's discussed at meetings. It's discussed at government now. There's a new COA grant that the Centre for Health Information got recently just to encourage more use of telemedicine. I'm not really seeing a coordinated move, well-coordinated move in that direction. And so I think that's the part that's lacking. But I think the literature would say, anyways, that patients they don't mind it, actually. So, which is a little bit surprising to me, in fact.
Really?
Yeah, I think I would have thought most people would prefer an in-person visit.
Yeah, okay.
Yeah.
We discussed that one, then.
Sure.
How much is the answer for that? And I think we're maybe eating around it. It's a bit like a few years ago, 10 years ago, Stephenville obstetrics. There was this massive political outcry because they couldn't recruit obstetricians because in the Stephenville area at the time, like 7 babies were being born a week. And you're not going to get or keep an obstetrician with that amount of activity, supposedly. And so you're going to midwives, and now there's a different end of the spectrum. But I think there's an expectation in this country, and we've been rich for a long time, with high fertility rates for a long time, that politically, as a community, we deserve a school, we deserve a hospital, we deserve a doctor, and by God, we're going to have it. And the politicians are expected by the voters to deliver. But if the demographics and the fiscal situation don't, something's got to give. Or is that a townie talking?
It's a politically charged issue, there's no question. One of my main interests is actually in my own rural, or my own main research interest is in rural obstetrical service delivery, actually.
I didn't know that.
And I've done...
He probably knows everything I just said was wrong.
Either that or it's going to Stephenville.
There's a heavy reliance in this province in particular, even more so than the rest of Canada, on specialist service delivery. The literature, the vast majority of the literature for appropriately chosen patients, so low-risk obstetrical patients, the outcomes are at least as good for deliveries by family doctors. So we rely too much on specialist delivery. We have 2 obstetrician obstetrical programs. like communities that have 2 obstetricians that are delivering a few hundred deliveries per year, which is a really expensive way of delivering the service when that's essentially all they do gynecology as well, but it's low use of their services, expensive services too. There are many communities, there are dozens of communities across Canada, small-ish rural communities that use GP surgeons, so special trained family physicians with additional year of surgical training to do cesarean sections, appendectomies. Many of them do scopes as well. And I've done some work looking at the outcomes from those providers, and they look really quite good. So I think we could be more cost effective, still provide obstetrical services in many small communities. We probably do need to rationalize a little bit, I think, and that is to close some hospitals. I think we probably have too many hospitals in this province. They're expensive to run, and the demographic change we've talked about just can't support them. I think that's the main. The cost of institutions is the main reason our health costs are so high. We're never going to get to the Canadian average because of the distribution of our population, but I think we can get closer by closing some hospitals. It's a hard decision to make. I know it's not a popular decision, but I think we can, we may even get better outcomes actually, because what you have in many of these tiny communities is they see severe medical problems only very rarely, so they're not comfortable dealing with them. They're not really appropriately trained when it comes right down to it to deal with them. I shouldn't say that. They've had the training, but they're just exposed to it so infrequently that they're just not comfortable doing it when they see it maybe once a year. Whereas if you have a provider in a larger center, they're seeing it every few weeks or every month, severe cardiac arrest or something like that, or major trauma or that sort of thing. So an extra few minutes of transport time to get to a provider that's doing this more often may actually result in better outcomes than seeing someone who is not as comfortable dealing with serious problems.
I think in Labrador, the extra few minutes is
well, yeah, and so what I'm saying really doesn't apply to much, if not all, of Labrador, to be honest, because there has to be an appropriate balance of geographic accessibility. I'm talking about, there are examples on the island, 2 quite small hospitals within half an hour's drive of each other. It probably doesn't make sense. Don't tell the people I said it from Central that I said this, but Gander and Grand Falls Windsor, in some cases, they're 2 quite large hospitals within half an hour, 45 minutes of one another. Now they service populations sort of spread out on each other side, so you might be able to justify it that way, but there are other examples that probably are not best use of resources, in my opinion.
And there's a lot of facilities in this province that are so underutilized in certain sections and age cohorts, it doesn't make sense to have some of the services there anymore.
Yeah.
You know, sort of thing. And that needs to be looked at as well. You know, sort of thing. Like if you're getting, you know, one youth patient, you know, every 6 months, does that justify having all those services? Like, one thing I liken to it, if you look at the system, we're dealing with a 1960s healthcare model that requires a 21st century application, you know, sort of thing. And I think that's got needs a rethink as well. And so, anyways.
I just want to go back to the telemedicine piece. The increased use of it, could that also be partly generational? I say that because I know my daughter who's out in British Columbia, and you know, they've had our granddaughter, but they're always on the phone talking to the healthcare provider about the baby all the time, rather than going in and visit a doctor. Now, my preference at my age would be to go in and see the doctor. I'm just wondering, you know, kind of the new technology and the approach younger people have, they'd be much more accepting of that system than what we currently have right now.
Yeah, we'll be seeing patients on Facebook, Facebook chat to see patients.
I think that's what they do.
Do they really?
I think so. Yeah, I believe they do. Yeah.
Well, Australia does a lot of telemedicine, right?
Yeah. And she's in her early 30s, right? So I'm just wondering if that's.
I suspect I've never seen analysis of that, but I mean I think you're probably right.
Put Ashley on the spot. Isn't your area or one of your areas Aboriginal health care?
Yeah, but more from the social determinants of health side rather than the health systems perspective. But I think, like, when you're talking about the telemedicine, and I think that you can probably respond to this, that I think when populations are used to working everything in virtually telemedicine and virtual medicine fits because you're so used to being on a screen, but there's still been issues and uncomfortability with Rosie. As amazing as she is, there's also it can be quite uncomfortable for
I can't
people.
speak much to the public health side because I'm not in the public health field, but yeah, I know that Rosie, even though, I know for a long time she had been used, but I think that it is being used more now, but you might even know, I'm not sure if you're familiar with the data.
Did you ever use Rosie?
No, I've never personally, but it's, I mean, it's worked well for people on,
Yeah.
you know, and if you can avoid travel as much as possible. Travel is such a huge expense in rural, certainly coastal, but for being referred to specialists in St. John's. From here, it's time consuming, it's expensive, and somehow that's got to be addressed, and whether
It's a little tiny bit off topic, but they recently brought the mobile X-ray machine to me too. And that was in response though to the TB cluster that happened.
The other thing we are looking at though is because I look at a lot of climate change and health pieces, is the impacts on climate change on weather, which then affect transportation, whether it's ferry or planes, which then affect health systems. Delivery, so you have lots of times where there are emergency situations and the transportation can't get in or out. So then in those cases, Rosie and or types of robots like that can be sometimes very life-saving.
So I just, and maybe Gary would have a thought, or is there any specific Aboriginal lens that the points Alvin and Kris are raising would need to be adjusted or adapted, or additional insights for them in their report? Or
well, we do have in our report, literature on, Aboriginal health and stuff like this, and context. A lot of the Saskatchewan work, was mostly based on First Nation Reserve sort of demands and stuff like this, and the problem of dispersion in small populations in some cases, and how you deliver that health care, sort of thing. But what needs to be done, I think, like there's a finer lens put to this and address those issues as well, sort of thing. Because I noticed, there's a flight 3 days a week out of Nain, 3 flights a week out of Nain that come here for people who need to see medevac for appointments and stuff, sort of thing. But again, you said that's if you're aged and you're, not very mobile, that's a tough ask sometimes, right?
There's a lot of work in Labrador, I mean, Nancy, that leads the majority of it around healthy aging from an Inuit perspective, and the Inuit Nation is leading an end-of-life care study right now from an Inuit palliative care approach. And I think Gary brought up an important point, like food is so important to that, and the traditional foods and access close to family, being on the land rather than in the hospital, a lot of preventative pieces, but also healthy aging and end-of-life pieces that are very different.
There are some things that I've seen when I came across in some jurisdictions, mobile health teams that would visit a community, not every couple of weeks or whatever, and follow up and stuff like this or whatever, But then there's a certain cost attached to that as well. But if it actually reduces the need to go into an acute care facility, well then that becomes a plus. There's probably a saving there at some point, right? So.
The Australians have done a lot of work on that as well, increasing access to rural Indigenous communities, really quite small communities, and I think the literature is pretty dramatic about the benefits.
Somewhat, or how are we doing?
We're getting done. If there are more questions, that's...
Well, I have a different point I want to raise. Well, they're somewhat related maybe, and I'd be interested if there's an Aboriginal angle on it. But it's something Don Hogan, who used to be at Alcoa, said he used to do a lot of demographic work, and God, that was 10 or 15 years ago. And he said that the drop in fertility rates in Newfoundland and Labrador, and I always say, it's true. My mom's a Bercy from Old Purlican, she was the youngest of 10. I had 54 first cousins, not to mention first cousin once removed, and they're mostly in the St. John's area. I've moved away a few times and come back every time. They drive you crazy when you're around them, but you can't stand to be away from them. And you know, funerals are social events and weddings and blah, blah, blah. And Don said several years ago, with most families now having fewer than 2 children, in the future, the Newfoundland child will not have a brother or a sister, will not have an uncle or an aunt, will not have a cousin. Now that blows my mind.
It's happening already in certain areas of
And so when you think of that minister in the UK, political minister for social isolation, and that importance of social connection for well-being, we gotta come up with dramatically different. I don't socialize much. I can't keep up with my mother. You know, and so how do we adjust?
Well, you point in case. I have 2 grandchildren. They've each got 1 cousin.
There you go. There you go.
And no brothers and sisters.
It'll be interesting. Newfoundland will be a particularly interesting test case in some ways because of, I mean, we all know we have really among the worst health outcomes in the country right now as a province, despite having, I think, the highest social cohesion scores.
So we get together and eat and drink.
Really sad.
But for the reasons you say, as those presumably the social cohesion will worsen, what will happen to our health outcomes? And it's going to be hard to attribute cause and effect because we're also implementing these chronic disease programs to improve our.
But it doesn't seem to be doing much for us at the moment, does it?
Well, maybe it is. Maybe we'd be way worse by then.
Counterfactual.
Yeah, actually, about I'm trying to think the number of years ago, well, at least 10 years ago or more, Community Health did a big survey and looking at perceived health and administrative health. And it's kind of interesting, is that as long as you have familiar support and whatever, even when you had X number of chronic diseases, you felt really well and you felt positive or whatever, but as soon as you lost that connection, all of a sudden you were, even though you're going to the hospital about the same amount of time, but your perceived health was worse and your outcomes were looking worse and whatever, and ultimately that makes you react in a certain way, you know, sort of thing, right? So, you know, it does have a place. And
perceived health has been a question on multiple StatsCan surveys for years, and despite what I just said, the worst outcomes in the country, really, for many indicators, Newfoundlanders' perceived health is among the best, if not the best.
Oh yeah, it is. And that survey reinforced that as well.
We think we're wonderful.
Thank you. One of the things that I'm interested in Labrador, because you brought up the population shift, is that's only for a certain population in Labrador. It's any population.
Yeah, like the North Coast is doing quite well. Central, exactly.
But then they also require, because they request culturally appropriate healthcare that is a different type of healthcare. So we have, you know, a growing population who's going to put different demands on the healthcare system to say we want health to be done differently that matches what we need, what we want, our land, our culture, you know, and so we have a shift here that's also demanding something different of a healthcare system that doesn't happen in other parts of the province. And I think that's a really interesting thing here is, you know, these population shifts, but then there's also demands for a different type of health and health responders, and they're asking clinicians to respond differently. And you can see it in the hospital here, you know, how pressures that are on clinicians to respond to different cultural requests in a way to be more welcoming and more effective. And so, I don't know, I think that's something to pay attention to here over the next couple of decades as well.
And generally, people's expectations are changing. So I get really annoyed if I have to wait as long as I used to, you know, I mean, for some kind of service. So there's a whole, I mean, it's just going to get worse in that sense, but in terms of extra demands on the system.
And I think the system needs to adjust to other people's understandings of what they need to be healthy.
Right.
And there's always a lag with that from it, so it'd be interesting. You got a lot of work to do. You have 20 or 30 years of study up here.
I don't know. I grew up in a remote community where you saw a doctor maybe once every 2 weeks that came into the clinic on a Wednesday from 1 to 4 p.m. and if you didn't get in, well, you had to wait another 10 days, you know, to see them. So I don't know where the expectations arrived from because in the past that wasn't there. sort of thing at the end of the day. And if you went to the cottage hospital and you got to go for some reason, it was probably a physician who did remove your appendix and did a really bad stitch job, sort of thing, but it wasn't a surgeon that did it, sort of thing, at the end of the day. So actually, that old model, there were very few specialists in rural Newfoundland at the time, sort of thing, right? So.
But you wouldn't put up with that, but, one doctor once every 10 days now, would you?
Help me?
Yeah.
I see my doctor twice a year.
Fine. Okay, fine.
And I have to, she told me. She said,
anyway, that's it. Any other thoughts or
except for kidney stones in the
things
emergency
that we
department.
should consider? Well,
So is there a follow-up to this session?
I'll leave this with you.
Okay, actually, there's something happening now. I can't say much about it, but we're looking at 140 community health centers in the province, and that includes the entire province. And I'm trying to get as much data as I can. There was a big survey done 2 years ago by the Department of Health looking at all the community health care centers and looking at what services they were providing, what their capacity was and staffing and all this other stuff. And so we really want to look at it and just see what's really going on. I think we're at scratching the surface, and I think there needs to be more in-depth analysis, and I think we need to get down to specific sub-regional demands and care that's going on, certainly personally. And you'd be surprising about how much information is not available, but yet there's a lot available, but sometimes you can't put it all together because you don't match up, for whatever reason. So. But yeah, we're continuing, and he's been roped into this now, so there's no escape. He's into the vortex of whatever, sort of thing. So yeah.
But from this work that's done now, there
Yeah.
will be a report's already essentially written.
Yeah.
And it'll be modified based on the feedback today,
Yeah.
and then made publicly available within a few weeks.
Yeah.
Right.
Just wondering how, what the engagement is with the province on this, from this group.
These guys are making some recommendations in their report. It remains to be seen, who do these best get directed to? So I'll have to leave them to answer that particular question.
So, my research, we work very closely with people in the Department of Health Office of Primary Care and about many different projects, and we produce short summaries to give to them, and we present to them, that sort of thing. I think it has some influence, and Alvin is talking.
I've actually
weekly as
given
well.
presentations directly to Minister Agee, Dr. Agee, and his staff. I've done several presentations, and that's why they gave us a grant to look at those community health centers. Because I've been pestering them, by the way, for over 2 years. And I don't give up once I latch on to something, sort of thing. But I have to admit, they were under a lot of pressure when he came on board to try and look at what's going on and sort things out. And finally this year they gave us a grant, sort of thing. So now we want to move this forward, but I think a lot more work needs to be done. I think people like Kris and his group and getting people like us who does analytics and modeling involved as well allows us to take this to another step and take it further, sort of thing. But I think we need some grassroots. We're believers in ground-up approaches, rather than top-down, sort of thing. And we just run across the numbers, but behind those numbers are people and their lives and their consequences. So we do take our work very seriously,
It's obvious that we cannot continue going the way we're going at the moment in terms of healthcare costs. There's got to be some fundamental changes. We've run out of money.
And Hagee does seem to be willing to say, I don't have a clue on the content, if it's right or wrong, but he seems to be willing to speak out on the tough issues. And John Abbott does.
Yeah. Yeah.
We have the best deputy minister of health in the country, in my opinion.
They say, I haven't seen the
Sorry, Kris.
They say that costs have flatlined the last 3 years. I haven't seen formal, external objective analysis, but
Well, like Kris says, the number of state aids and hospitals are reduced dramatically. I know from when I looked at some data, we looked at, I forget what years, what was it, I think it was 2010 or 2009, it was average number of days, stays about 10. Now it's down to 6. And that's been going down like this, sort of thing. But there's probably a bottom out number there somewhere where, it'll flatten out and not change anymore, right? Sort of thing. But it has been reduced quite a bit,
But yet our costs are still increasing.
Yeah, this is the issue that you gotta get at as well, right? Is that, patients staying less time, but yet the costs. But I think there's other things related to that, sort of thing, is the demand and the level of diagnostics that you're going with, and using more specialists, as Kris brought up, which is very expensive, as opposed to using more physicians or, nurse practitioners and stuff like this in certain situations where it's viable. Sort of thing that without, as they say, where the risk is low. I mean, studies have shown that these things work.
Our CT scan ordering rate in the province, I think, is double the national average, and the highest among the provinces. So things like that. And each CT scan is a few $100s. So it all adds up.
Yeah. I've had a few of those. You want to mean about getting more expensive by the day. Anyway, I think we're timed out, and I'm sure Kris and Alvin are happy to entertain any more questions for a little while afterwards. But thank you all very much for coming. Thank you, Ashley, and
Jamie deserves all the thanks.
Jamie for hosting, organising us. Much appreciated.
Viewing online, we appreciate it.
Yeah. And I think we've had some productive sessions today, and we thank you very much indeed for participating.
Thanks for allowing us to, come here and share some of the things.
It's our pleasure.
Well, I hope you keep. We'll send out information out when these reports, this particular one and others, are ready. Keep an eye out at the Harris Centre website. They'll all be up there and available. And
I get emails from the Harris Centre.
Sure, good. Well, then
Harassment centers. Infiltrate.
My grandmother from Jackson grew up.
And there's still lots of veggies and cheese. Fill your pockets.
Thank you very much, everyone.